Hi all, welcome to RAAONLINE. Today we are going to see about one wonder drug in anesthesia. That is nothing but Dexmedetomidine. Dexmedetomidine is a highly selective alpha-2 adrenoreceptor agonist. It is sympatholytic, analgesic and sedative, which makes it as an attractive option for anesthesia adjuvant, not only in the operating room but also in the intensive care unit. It is usually preferred for conscious sedation of adults and children during diagnostic and surgical procedures. Coming to the structure, it is an active dextroisomer of metidomidine and imidazole group, which is a veterinary sedative and analgesic. It is presented as a clear colorless solution of 100 microgram per ml of dexmedetomidine hydrochloride, which is diluted with normal saline to a concentration either of 4 microgram per ml or 8 microgram per ml. Here it is an imidazole derivative from which dimetomidine comes in. From there medetomidine comes in, and later we have dexmedetomidine. The chemical formula is C13, H16 and N2, and the chemical name is dimethylphenylethyl imidazole. Coming to administration, it is usually administered in the intravenous route. The loading dose is usually 1 microgram per kilogram over a period of 10 to 20 minutes, followed by an infusion dose which can range between 0.2 to 0.7 microgram per kilogram per hour. The rate of infusion can be increased in increment of 0.1 microgram per kilogram per hour or even higher. Coming to intramuscular, the dose is around 2.5 microgram per kilogram. Intramuscular is usually used for pre-medication. Coming to spinal, it is given in the dose of 0.1 to 0.2 microgram per kilogram. In epidural, it is used in the dose of 1 to 2 microgram per kilogram. Peripheral nerve blocks, it is 1 microgram per kilogram. And in buccal, it is 1 to 2 microgram per kilogram. Intranasal, particularly in pediatric group, it is 1 to 2 microgram per kilogram. On intravenous administration, it exhibits two compartment kinetics, peripheral and the central compartment. There is rapid redistribution, including it crosses the blood-brain barrier and the placenta. It is highly protein bound, and in the steady state, the volume of distribution is roughly around 1 to 2 liter per kilogram. In pediatric age group and in neonates, this may be increased. This volume of distribution may be increased, and it varies widely in critical ill patients. As I said earlier, it is a two compartment distribution, and here you can see in the usual dose of 0.2 to 0.7, the concentration is roughly around 1 nanogram per ml. As the infusion increases to 1 to 1.2 microgram per kilogram per hour, the concentration increases to 2 nanogram per ml, and the clearance is roughly around 40 liters per hour, and you can see with increasing dose it is almost the same 40 liters per hour. The distribution half-life is 6 minutes and elimination half-life is 2 hours, and here the volume of distribution is 118 liters and the clearance, as I said earlier, it is roughly 39 to 40 liters per hour. Coming to the bioavailability, the oral route, the bioavailability is 16%. Intramuscular, it is 73%, and intranasal, it is 84%. Distribution of life 6 minutes, elimination of life 2 to 4 hours. Volume of distribution is 1 to 2 liter per kilogram, and the clearance is 0.5 liter per kilogram per hour. And 99% of dexmedetomidine is metabolized by the liver. The extraction ratio by liver is 0.7. and unchanged excretion is 1%, and 94% of dexmedetomidine is bound to protein, mainly to albumin. The urinary excretion is around 96% and the fecal excretion is around 4%. And with onset of action in IV, it is 5 to 10 minutes. In nasal, it takes around 45 to 60 minutes. Peak effect with IV loading is 15 to 30 minutes and nasal, it is 46 to 47 minutes. And the duration of action is 60 to 120 minutes and it is dose dependent. Coming to metabolism, it is metabolized in the liver via N-glucuronidation, which is about 41%. About 21% here it undergoes methylation and conjugation. Another 14% is metabolized by cytochrome P50 catalyzed oxidation and hydroxylation. All this are metabolized to inactive metabolites, which is 95% of the metabolites are excreted in the urine. Coming to a few salient points, the estimated context-sensitive off time of dexmedetomidine is favorably short between 1 to 4 hours. Thus, elimination of life is similar following single dose or infusion of more than 24 hours. There is no major difference in renal impairment. However, off-life prolongation and reduced clearance happens with hepatic impairment. Your liver is very important for metabolism. With regard to obesity, you should use the lean body mass index rather than actual body weight for dosing dexmedetomidine. And coming to the various alpha-2 receptor, it is subdivided into 4 major categories: 2A, 2B, 2C and D. Here I have put only 3 subcategories. With regard to agonist, clonidine is more of alpha-2A than alpha-2B and C. Guanfacine, it is mainly alpha-2A only, but dexmedetomidine acts on all 3 subgroup of alpha-2 receptor, and it is highly selective alpha-2 with the ratio of 1:1620 when compared between alpha-1 and alpha-2. With regard to clonidine, it is approximately 8 times more selective for alpha-2 receptor than clonidine. Dexmedetomidine also have some affinity for I receptor, which is imidazolin receptor, and whether this contributes to sympatholysis, sedative and analgesic effect is yet to be seen. And coming to the cellular level action of dexmedetomidine, the alpha-2 adrenoreceptor is a G protein coupled receptor. Normally in the resting state, this GDP, the gynosin diphosphate, is bound to subunit of G protein, which is itself bound to the receptor. Here, once you give dexmedetomidine, it binds to the alpha-2 receptor, which causes a conformational change in the G protein. This results in the activation of GA subunit, alpha subunit of G protein, and the exchange of GDP to GTP happens. Here you can have the GTP. So, as the dexmedetomidine goes to alpha-2 receptor, some changes happen in G protein and this alpha subunit gets exposed and GTP becomes GTP. Now, as the dexmedetomidine has bound to the G protein receptor, this beta and gamma dissociates from the complex and activates inward rectifier potassium channels, thereby potassium efflux happens and there is hyperpolarization of nerve terminal. This is the second change which happens. As potassium increases and hyperpolarization happens, this in turn inhibits voltage gated calcium channel. So, your calcium is inhibited. This reduced calcium impairs the secretion of neurotransmitter. So, this is the final step. Your neurotransmitter release is prevented by addition of dexmedetomidine to alpha-2 receptor. In parallel, the activated G protein GTP complex also inhibits adenyl cyclase, thereby reducing CAM production, which has multiple downstream effects. This is how the stimulation of alpha-2 receptor happens at the cellular level. Now coming to the systemic effect. When you have a surgery, the stress of surgery activate two axes. One is hypothalamo-pituitary axis, another is sympathetic adrenomedullary axis. Two axes are being activated. This hypothalamus pituitary axis will stimulate the adrenal gland and release cortisol. This sympathetic nervous system will cause the release of epinephrine and norepinephrine through locus coeruleus. Another important thing which happens with the stress of surgery is inflammatory response, where your cytokines goes up and there is decreased immune function, which is mediated via T cells, B cells and natural killer cells. Now, by giving dexmedetomidine, you are stimulating the alpha-2 receptor, you are suppressing the HPA axis, you are suppressing the sympathetic nervous system axis, and you reduce the inflammatory response. You decrease the pro-inflammatory cytokines and increase your anti-inflammatory cytokines. And through immunity, it improves the immunity function, it improves the innate immunity and increases the adaptive immunity too. So, with dexmedetomidine, you reduce cortisol, you reduce norepinephrine and epinephrine, you reduce the inflammatory mediator and improve the immune function too. The foremost action of dexmedetomidine is to prevent the release of norepinephrine. Normally, at the neuromuscular junction, you have the synaptic vesicle which releases norepinephrine, and this norepinephrine combines with alpha-1 receptor and causes vasoconstriction. This is alpha-2 receptor. This dexmedetomidine goes and combines with alpha-2 receptor and sends a negative feedback to the synaptic vesicles not to release the norepinephrine. So, norepinephrine does not bind with alpha-2 receptor and vasoconstriction is prevented. Second, how it helps is by via attenuation of calcitonin gene related peptide. Through this calcitonin gene related peptide, it prevents the nociceptive signal. So, nociception acts through CGRP, which is prevented with the dexmedetomidine alpha-2 combination. In summary, what are the various effects of alpha-2 receptor? Through alpha-2A, it causes sedation, it reduces the heart rate or decrease tachycardia, both amounts to decreasing the rate. It produces analgesia and causes vasodilatation. These are all mediated by alpha-2A. Through alpha-2B, it causes vasoconstriction. You have to remember that in high doses, it can stimulate, it can cause vasoconstriction, that is mediated by alpha-2B. Apart from that, anti-shivering and diuresis are thought to be mediated by alpha-2B. And the final anxiolysis, also alpha-2A plays a role, alpha-2C also plays a role in anxiolysis. The sedative effect of dexmedetomidine or through activation of pre and postsynaptic alpha-2 adrenoreceptor in the locus coeruleus, the main non-adrenergic nucleus in the pons. The analgesic effect are thought to be mediated by central nociceptive receptor activation, resulting in interneuron hyperpolarization, thereby reducing the neurotransmitters like glutamate and substance P, which are all pain producing substance. And when you give dexmedetomidine, with regard to hemodynamics, there is a biphasic response. What is this biphasic response? You have mean arterial pressure this side, the heart rate on the other side, and this is the concentration. This is low concentration, this is high concentration. Now, with regard to blood pressure, at low concentration, there is hypotension, and at high concentration, there is hypertension. This is alpha-2A and this is alpha 2b. At high concentration, it stimulates alpha 2b and causes hypertension. But the heart rate at high concentration comes down. So, following a bolus dose, a high plasma concentration stimulates alpha 2b mediated vasoconstriction, causing a transient rise in blood pressure, and this causes a reflex reduction in heart rate. Then as concentration comes down, presynaptic alpha 2 receptor in the locus coeruleus reduces catecholamine surge, causing a fall in blood pressure. And a similar effect can be seen with infusion. At low infusion, hypotension predominates. However, as infusion rate increases, your blood pressure increases and may surpasses your blood pressure. This is because this high concentration might stimulate the alpha 2b receptors. So, coming to the summary with alpha 2 receptors, due to alpha 2a stimulation, you have analgesia, sympatholysis, sedation, anxiolysis, hypnosis, and a good cooperation with the patient. So, it can be an ideal anesthetic adjuvant. With alpha 2b, there is vasoconstriction and hypertension. Alpha 2c, there is an anxiolysis and drug withdrawal. The alpha 2d action is still unknown. Now, coming to the clinical effect, what happens if you give dexmedetomidine? At the central nervous system level, there is a arousable sedation which resembles normal sleep, which is very important, with preserved muscle tone and ventilation. And it produces analgesia, it reduces cerebral blood flow and cerebral metabolic requirement of oxygen. With respiration, there is minimal change in ventilatory function, mild increase in respiratory rate, mild decrease in tidal volume, but your hypercapnic drive and airway reflexes are well maintained. Coming to endocrine, there is a theoretical risk of adrenal suppression being an imidazole derivative, but which is clinically not significant. It decreases the renin release as well as the insulin release, which are also clinically not significant. With respect to cardiovascular system, as I said earlier, there is going to be a biphasic response, but usually what textbook says is hypotension and bradycardia, and your cardiac output may be decreased because of decreased heart rate, but it does not affect the stroke volume. In some cases, you will have severe bradycardia and asystole, particularly when used in very high concentration. With regard to gastrointestinal system, it decreases the bowel motility, and with renal, there is decreased antidiuretic activity on the distal convolutional tubule, causing diuresis. These are all the systemic effects of dexmedetomidine. Other effects include, it is an antisyllagogue, decongestant, and one more important side effect of dexmedetomidine is hyperthermia. Coming to adverse effect, can be hypotension, hypertension, bradycardia, dry mouth, nausea, and sometimes atrial fibrillation and hypoxia can happen with dexmedetomidine. Overdose can cause first degree or second degree AV block, which might be a troublesome in an anesthesia for electrophysiological procedure. And an uncommon side effect which I mentioned in the previous slide is hyperthermia. It is important differential diagnosis in hyperthermia, or it is an important differential diagnosis in unexplained pyrexia to avoid assumption that infection is causing hyperpyrexia. Most of the time you assume that it is infection and you start an antibiotic. It might be dexmedetomidine infusion which is causing that hyperthermia. Now coming to the interaction, co-administration of dexmedetomidine with inhalational and intravenous anesthetic agent along with benzodiazepine and opioids will accentuate the adverse effect of dexmedetomidine. Another important thing is agents which causes bradycardia and hypotension such as beta blocker. You should be very careful. Here the co-administration of beta blocker and dexmedetomidine can cause severe bradycardia leading to asystole. Coming to withdrawal. Withdrawal symptoms from dexmedetomidine includes hypertension, tachycardia and agitation. This happens with prolonged infusion, particularly in intensive care unit. This is due to higher infusion rate. Infusion rate greater than 0.8 microgram per kilogram per hour and the cumulative dose is 12 microgram per kilogram per hour. It may be prudent to avoid abrupt discontinuation. Here, you just should not stop the dexmedetomidine, but you should wean the infusion over several hours. In case withdrawal is there, clonidine can be used as an alternative tapering agent. Here, it reduces the duration of dexmedetomidine treatment and at the same time, by replacing with clonidine, you facilitate the ongoing alpha-2 adrenoreceptor agonism and its beneficial effect. This happens in a non-critical care environment. The usual weaning is, first you have decided to wean the dexmedetomidine, reduce the rate by 25%. After 6 hours, another 25%. Then another 12 hours you reduce by 75%. So, by 18 hours, you reduce by 75%. Followed at the end of 18 hours, you switch off the dexmedetomidine. So, overall, the weaning of dexmedetomidine should be done over a period of 18 to 24 hours. Now, coming to the indications for dexmedetomidine. It can be an anxiolysis, anti-sialagogue and sedation. It makes a attractive pre-medication. Attenuation of intubation response and stable hemodynamics makes it as a wonderful choice for perioperative use, particularly in high-risk patients and coronary artery disease. In these patients, you want to avoid the intubation response, so dexmedetomidine will be an ideal agent there. It produces analgesia, sedation and reduction of dose of general anesthetics and opioid. So, it can be an adjuvant in general anesthesia. Reduction in dose and prolongation of action of local anesthetic and anti-shivering. It can be an adjuvant in local regional anesthesia. Sympatholysis and renal protection. Clinical use can be used in controlled hypotension. Bioavailability by various non-invasive route, minimal respiratory effect, smooth induction and emergence. This makes it an attractive choice for pediatrics as well as in conscious sedation under monitored anesthesia care. Minimal respiratory effect and stable hemodynamics. It can be used in upper airway surgery and morbidly obese patient. And it can control the post-operative delirium and agitations, which makes it is clinical use in cognitive disorder. It can be used in metatorofitinal surgery and nowadays in joint surgery, it is used in intra-articular injections too. Coming to the dose which is used for awake fibre-optic intubation, the loading dose is 1 microgram per kilogram over 10 to 15 minutes. Followed by an infusion of 0.2 to 0.7 microgram per kilogram per hour titrated to the effect. For example, if the patient is 60 kgs, you give a dose of 60 microgram over a period of 10 to 15 minutes, then it will be 0.7 microgram per kilogram per hour, which is roughly 42 microgram per hour. This you can administer when you are giving regional anesthesia to the airway. And if additional sedation is required, you can add midazolam. Coming to pediatric procedural sedation, here you give 2 to 4 microgram per kilogram intranasally via mucosal automation device. In pre-medication in children, you give 2 microgram per kilogram intranasally via automation device. If the child is around 20 kgs, it is going to be 40 to 80 microgram for procedural sedation. In pre-medication, it is going to be 40 microgram. But most important thing is intranasally it will take at least 40 minutes to act. So, you have to wait patiently for at least 40 minutes after administering intranasal dexmedetomidine. If optimal sedation is not achieved even after this, it can be supplemented with oral midazolam. So, what is the Periprocedural application of dexmedetomidine. First is anxiolysis. It is easy and quick arousal from sedation. There is minimal respiratory depression and it attenuates a sympathetic hemodynamic response. Coming to intraoperative application in airway procedure. It can be used for rigid bronchoscopy, sleep endoscopy, MRI, sleep studies, open thyroplasty, mediastinal mass biopsy or difficult intubation. Here, it obtains the airway reflex but maintains the stable hemodynamics and respiratory profile in spontaneous ventilation. It maintains the airway reflex but obtains slightly. In sleep studies, it provides sedative properties which resembles natural sleep. That is very important. Coming to neurosurgery, in posterior spine fusion, it lowers the requirement of propofol and inhalation agent, and most importantly, it facilitates intraoperative wake-up test. And in brain tumor and epileptic seizure foci resection, it preserves epileptiform activity, allows comfortable and cooperative sedation. With regard to cardiac surgery, it blunts the sympathetic response, provides analgesia, sedation in the postoperative period and exhibits early extubation. Coming to painful procedure, extracorporeal shockwave lithoscopy, dressing change and burns, lumbar puncture, bone marrow biopsy, central venous placement or chest tube insertion. Here, combining ketamine with dexmedetomidine in this procedure provides good sedation, analgesia, amnesia and hemodynamic stability. Coming to application in the postoperative period, in adenotonsillectomy, it reduces the incidence of emergent situation which becomes very dangerous in case of tonsillectomy. It reduces the opioid requirement, it reduces the episodes of oxygen desaturation. Particularly, this comes in handy in cases of obstructive sleep apnea. Apart from that, in the postoperative period, it is shown to reduce shivering and emergence agitation. Coming to the dosings in various applications, in anxiolysis, you can use buccal at a dose of 1 microgram per kilogram. Intranasal, it is 0.5 to 2 microgram per kilogram. Airway procedure, you give a loading dose of 0.5 to 2 microgram per kilogram over 10 minutes, followed by an infusion of 0.3 to 3 microgram per kilogram per hour. In posterior spine fusion, it is IV and it is a dose of 0.1 to 0.5 microgram per kilogram per hour. Here, you target a plasma concentration of 0.4 nanogram per ml. In brain tumor and epileptic seizure surgery, it is given IV at a dose of 0.1 to 0.5 microgram per kilogram per hour. Cardiac surgery, you give a bolus of 0.5 to 1 microgram per kilogram bolus followed by a 0.5 microgram per kilogram per hour infusion. Adenotonsillectomy, it is 0.5 to 1 microgram per kilogram, and in postoperative shivering, it is 0.5 microgram per kilogram. In emergence, it is 0.2 to 1 microgram per kilogram, all given in IV route. Coming to neurosurgery. How dexmedetomidine is a neuroprotective agent. Here, during surgery, there is an harmful autophagy. By dexmedetomidine combining with the imidazole 2 receptor, this harmful autophagy is converted into a beneficial autophagy. Apart from that, it prevents the calcium influx and it also reduces the cellular stress and ischemia. By doing these 3 different things, it gives safe and effective neuroprotection, reduces delirium, and there is a modest effect on brain electrophysiological property. So, dexmedetomidine nowadays is being used as a neuroprotective agent. Now, coming to cardioprotection. Here, it reduces reactive oxygen species and matrix metalloproteinases. By doing that, it decreases the fibrosis and helps in remodeling. By cardiac preconditioning, it prevents the ischemic reperfusion injury, and at the endothelium, it decreases the inflammation and increases the nitric oxide synthase and nitric oxide, thereby cardiomyocyte is nicely developed and it prevents the cell death. All this leads to cardioprotection and improved cardiovascular outcome. It reduces the time of stay in ICU, reduces the delirium, reduces the risk of abdominal hemodynamics, that is very important, reduce inhalational requirement and decrease surgical risk. All will come in handy during cardiac surgery. Coming to obstetric anesthesia, it lowers the intensity and incidence of shivering, reduce anesthetic agent requirement, prolongs the duration of analgesia and optimizes analgesia to renal protection in preeclampsia, enhance patient recovery quality and comfort, and enhance lactation. Coming to Onco Surgery, it attenuates immunosuppression, effective cardiocerebral protection, enhance post-operative cognitive function. It prevents cognitive dysfunction, improves post-operative analgesia, and reduce opioid consumption. And another important thing is regional anesthesia. What is the role of dexmedetomidine in regional anesthesia? The first and foremost is faster onset of action, rapid establishment of both sensory and motor blockade, prolonged duration of analgesia extending into the post-operative period, and the dose of local anesthetic is coming down, stable cardiovascular parameter, provides good sedation and anxiolysis. Dose in spinal is around 3 to 15 microgram and epidural it is 1 to 1.5 microgram per kilogram, and 0.5 microgram per kilogram dexmedetomidine to lidocaine for intravenous regional anesthesia improves the quality of anesthesia and also improves post-operative analgesia without causing much side effects. So, it can be used in IVRA too. The addition of dexmedetomidine to local anesthetics in peripheral nerve block have significantly shown to prolong the duration of analgesia by approximately 5 hours. Perineural dexmedetomidine does not cause any neurotoxicity. However, hypotension and bradycardia can happen. Doses from 2 to 20 microgram have been used without significant difference in duration of action and without much adverse effects. So, to conclude, dexmedetomidine is an highly selective alpha-2 adrenoreceptor agonist, and most importantly, it has multiple application in anesthesia as well as intensive care unit. It exerts its effect via inhibition of noradrenaline release in noradrenergic neuron. The side effects are dose dependent and include bradycardia and hypotension. Due to its sympatholytic, analgesic and sedative effect, it is an attractive option for pre-medication and procedural sedation both in adult and pediatric population. It can be used as an analgesic adjunct in which opioid sparing regime is desirable, particularly in bariatric surgery. Dexmedetomidine has a developing role as an adjunct in regional and neuraxial anesthesia. A thorough understanding of its mechanism of action and potential side effect will allow the anesthesiologist to use it safely and effectively and improve the perioperative outcome. Further research is required to explore its use in novel areas such as opioid sparing analgesic regimens. Thank you.